Ionised calcium is responsible for a variety of physiological processes. Cellular secretion, excitable tissue function, contraction and clotting are all examples of calcium-dependent processes. Normal plasma calcium levels include that bound to proteins, ionised calcium and complexed calcium, totalling between 2.10 to 2.55 millimoles per litre. About 50% of calcium is ionised in health, ranging from 1.15 to 1.30 milliequivalents per litre. Pathological processes may reduce the plasma protein level. However, ionised calcium is tightly controlled by homeostatic mechanisms. As a rule, the total calcium is reduced by 0.02 millimoles per litre for every 1 gram per litre that the plasma albumin falls below 40 grams per litre, and it is possible to correct plasma calcium in cases of hypoalbuminemia. In ICU practice, however, ionised calcium measures are readily available through blood gas testing. Similarly, pH variation also alters protein binding. For each 0.1 fall in plasma pH, the ionised fraction of calcium increases by 0.07 milliequivalents per litre. Smaller changes occur in the presence of organic substances that complex calcium, such as lactate, bicarbonate and citrate. In pharmacological doses, each may become important. Ionised calcium is detected by the chief cells of the parathyroid gland. In the presence of low calcium levels, the chief cells secrete parathyroid hormone, or PTH, but release is suppressed in the presence of hypercalcemia and by the action of vitamin D. Parathyroid hormone is a polypeptide with a half-life in the serum of about 10 minutes. It is produced by the parathyroid gland by removal of 2 polypeptide sections from the precursor molecule. PTH acts on bone and kidney to increase the retention and liberation of calcium. The effects on the bone are enhanced by vitamin D, which is associated with a rise in plasma alkaline phosphatase. At the kidney level, PTH acts on the tubules to promote calcium retention, while simultaneously enhancing phosphate loss. Furthermore, PTH assists with the activation of vitamin D, which enhances gut resorption of calcium and phosphate. The production, release and action of PTH is magnesium dependent, and hypocalcemia can be associated with primary hypomagnesemia. The main controller of vitamin D activity is its conversion into the dihydro form by the 1-alpha hydroxylase enzyme, which is itself controlled by PTH secretion, by serum phosphate levels, and by negative feedback from active vitamin D. Rarely, the dihydro form can be produced in excess in granulomatous diseases such as sarcoid, resulting in hypercalcemia. In summary, in response to hypocalcemia, PTH is released, which results in increased renal tubular calcium retention and phosphate excretion, increased 1-alpha hydroxylase production, which then increases active vitamin D. This increases gastrointestinal absorption of calcium and also phosphate, which counterbalances the primary phosphate loss, and bone mobilisation of calcium and phosphate. The net effect is to increase calcium with negligible change in the phosphate level. The earliest and most common feature of acute hypocalcemia is tetany, usually involving the small muscles of the extremities and the larynx. Clinical signs of Chvostek sign and Trousseau's sign may be seen. Hyperventilation may also provoke these symptoms. Paresthesias, cramps, confusion, areflexia and hypotension may also occur. Calcium is an important cofactor for the coagulation pathway. Hypocalcaemia may be a contributor to coagulopathy in patients with critical bleeding, and replacement should be considered. Hypocalcaemia in critical illness is usually multifactorial and probably relates to defects in absorption, bone mineralisation, bone mineral regulation and loss. Some common causes of low ionised serum calcium are shown below. Prolonged elevation of inflammatory cytokines such as TNF-alpha and interleukin-6 associated with immobility can lead to increased bone resorption in ICU patients. This can be associated with high, low or even normal plasma calcium levels. What is clear is that bone resorption is common and may result in an increase in gravity-related fractures in survivors of ICU. The loss of bone minerals is difficult to combat. Research is underway to examine the role of bisphosphonates in preventing this condition. Citrate is an organic acid that is used largely as an anticoagulant in clinical practice. Massive blood transfusion can result in accumulation of citrate and clinical hypocalcaemia. Similarly, citrate is sometimes used as an anticoagulant in renal replacement and plasmapheresis circuits. Low magnesium levels suppress all levels of the PTH pathway and can result in clinical hypocalcaemia. Replacement of magnesium may facilitate correction of calcium. Rarely, poor gut absorption of vitamin D may contribute to hypocalcaemia. Rhabdomyolysis and pancreatitis may release compounds that complex calcium in a similar fashion to citrate. This can lead to profound hypocalcaemia and may be refractory to treatment. Hypophosphatemia may also lead to a low ionised calcium level. In rare cases, burns associated with hydrofluoric acid may cause profound hypocalcaemia. Hyperphosphatemia may also lead to a low ionised calcium level. The byproducts of certain toxins may also be responsible for hypocalcaemia. Oxalic acid, produced in ethylene glycol toxicity, avidly binds calcium. Diuresis is a common cause of calcium loss, particularly if due to loop diuretics, which directly inhibit its reabsorption. Calcium is also lost from renal replacement therapies. Other causes exist. As a general rule, hypocalcaemia is only treated in symptomatic patients. Calcium comes in a number of formulations. A common form, 10% calcium chloride, contains 6.8 millimoles in 10 mils. An alternate form, 10% calcium gluconate, contains 2.2 millimoles. In acute situations, calcium can be rapidly administered over 3 to 5 minutes. Bolus therapy is associated with nausea and flushing. Ideally, either a central or large bore peripheral vein should be used, and if in doubt, the use of the gluconate form is safer as it is less associated with extravasation necrosis, bearing in mind that the quantity of calcium is less for the same volume administered. For persistent hypocalcaemia, an intravenous infusion of calcium chloride can be given at the rate of 1 to 5 mils per hour, aiming for an ionised calcium level higher than 0.8 millimoles per litre. In less acute cases, oral supplements of calcium in the range of 2 to 4 grams per day and vitamin D 0.25 to 1.0 micrograms per day can be given.